Welcome to the Dr. Izzy's Medical Podcast channel.
Addison's disease. Addison's disease, also known as primary adrenal insufficiency and hypocortisolism, is a rare long-term endocrine disorder characterized by inadequate production of the steroid hormones cortisol and aldosterone by the two outer layers of the cells of the adrenal glands, causing adrenal insufficiency. Symptoms generally come on slowly and insidiously and may include abdominal pain and gastrointestinal abnormalities, weakness, and weight loss. Darkening of the skin in certain areas may also occur. Under certain circumstances, an adrenal crisis may occur with low blood pressure, vomiting, lower back pain, and loss of consciousness. Mood changes may also occur. Rapid onset of symptoms indicates acute adrenal failure, which is a serious and emergent condition. An adrenal crisis can be triggered by stress, such as from an injury, surgery, or infection. Addison's disease arises from problems with the adrenal glands such that not enough of the steroid hormone cortisol and possibly aldosterone are produced. In developed countries, the etiology of Addison's disease is often attributed to idiopathic damage by the body's own immune system, and in developing countries most often due to tuberculosis. Other causes include certain medications, sepsis, and bleeding into both adrenal glands. Secondary adrenal insufficiency is caused by not enough adrenocorticotropic hormone or corticotropin-releasing hormone. Despite this distinction, adrenal crises can happen in all forms of adrenal insufficiency. Addison's disease is generally diagnosed by blood tests, urine tests, and medical imaging. Addison's disease can be described in association with chronic mucocutaneous candidiasis, acquired hypoparathyroidism, diabetes mellitus, pernicious anemia, hypogonadism, chronic and active hepatitis, malabsorption, immunoglobulin abnormalities, alopecia, vitiligo, spontaneous myxedema, Graves' disease, and chronic lymphocytic thyroiditis. Treatment involves replacing the absent hormones. This involves taking a synthetic corticosteroid, such as hydrocortisone or fludrocortisone. These medications are usually taken by mouth. Lifelong, continuous steroid replacement therapy is required, with regular follow-up treatment and monitoring for other health problems. A high-salt diet may also be useful in some people. If symptoms worsen, an injection of corticosteroid is recommended and people should carry a dose with them. Often, large amounts of intravenous fluids with the sugar dextrose are also required. Without treatment, an adrenal crisis can result in death. Signs and symptoms. The symptoms of Addison's disease generally develop gradually. Symptoms may include fatigue, muscle weakness, weight loss, nausea, vomiting, loss of appetite, lightheadedness upon standing, irritability, depression, and diarrhea. Some people have cravings for salty foods due to the loss of sodium through their urine. Hyperpigmentation of the skin may be seen, particularly when the person lives in a sunny area, as well as darkening of the palmar crease, sites of friction, recent scars, the vermilion border of the lips, and genital skin. These skin changes are not encountered in secondary and tertiary hypoadrenalism. Skin changes. Hyperpigmentation of the skin. Vitiligo. Gastrointestinal changes are nausea and vomiting. Weight loss. Abdominal pain. Less common but still occurring, malnutrition and muscle wasting. Behavioral disorders are anxiety, depression, irritability, poor concentration. Changes in females are loss or irregularity of menstrual cycle, loss of body hair, decreased sexual drive. On physical examination, these clinical signs may be noticed. Low blood pressure with or without orthostatic hypotension, darkening of the skin, including areas not exposed to the sun. Characteristic sites of darkening are skin creases, nipple, and the inside of the cheek. Also, old scars may darken. This occurs because melanocyte-stimulating hormone and ACTH share the same precursor molecule, pro-opiomelanocortin. After production in the anterior pituitary gland, POMC gets cleaved into gamma-MSH, ACTH, and beta-lipotropin. The subunit ACTH undergoes further cleavage to produce alpha-MSH, the most important MSH for skin pigmentation. In secondary and tertiary forms of adrenal insufficiency, skin darkening does not occur as ACTH is not overproduced. Addison's disease is associated with the development of other autoimmune diseases, such as type I diabetes, thyroid disease, celiac disease, or vitiligo. Addison's disease may be the only manifestation of undiagnosed celiac disease. Both diseases share the same genetic risk factors. The presence of Addison's, in addition to mucocutaneous candidiasis, hypoparathyroidism, or both, is called autoimmune polyendocrine syndrome type. The presence of Addison's in addition to autoimmune thyroid disease, type 1 diabetes, or both, is called autoimmune polyendocrine syndrome type 2. And what is adrenal crisis? An adrenal crisis or Addisonian crisis is a constellation of symptoms that indicates severe adrenal insufficiency. This may be the result of either previously undiagnosed Addison's disease, a disease process suddenly affecting adrenal function, or an intercurrent problem in someone known to have Addison's disease. It is a medical emergency and potentially life-threatening situation requiring immediate emergency treatment. Characteristic symptoms are sudden penetrating pain in the legs, lower back, or abdomen. Severe vomiting and diarrhea, resulting in dehydration. Low blood pressure. Syncope, loss of consciousness and ability to stand. Hypoglycemia, reduced level of blood glucose. Confusion, psychosis, slurred speech. Severe lethargy. Hyponatremia, low sodium level in the blood, hyperkalemia, elevated potassium level in the blood, hypercalcemia, elevated calcium level in the blood, convulsions. Fever. Causes of Addison's disease. Causes of adrenal insufficiency can be categorized by the mechanism through which they cause the adrenal glands to produce insufficient cortisol. This can be due to damage or destruction of the adrenal cortex. These deficiencies include glucocorticoid and mineralocorticoid hormones as well. These are adrenal dysgenesis, impaired steroidogenesis, or adrenal destruction. Autoimmune adrenalitis is the most common cause of Addison's disease in the industrialized world. Autoimmune destruction of the adrenal cortex is caused by an immune reaction against the enzyme 21-hydroxylase. This may be isolated or in the context of autoimmune polyendocrine syndrome, in which other hormone-producing organs, such as the thyroid and pancreas, may also be affected. Adrenal destruction is also a feature of adrenal leukodystrophy, and when the adrenal glands are involved in metastasis, hemorrhage, particular infections as like tuberculosis, histoplasmosis, coccidioidomycosis, or the deposition of abnormal protein and amyloidosis. Adrenal dysgenesis. All causes in this category are genetic, and generally very rare. These include mutations to the SF1 transcription factor, congenital adrenal hypoplasia due to DAX1 gene mutations, and mutations to the ACTH receptor gene. DAX1 mutations may cluster in a syndrome with glycerol kinase deficiency with a number of other symptoms when DAX1 is deleted together with a number of other genes. Impaired steroidogenesis. To form cortisol, the adrenal gland requires cholesterol, which is then converted biochemically into steroid hormones. Interruptions in the delivery of cholesterol include Smith-Lemli-Opitz syndrome and abetalipoproteinemia. Diagnosis in Addison's disease. Suggestive features in routine laboratory investigations may show low blood sodium, due to loss of production of the hormone aldosterone, to the kidney's inability to excrete free water in the absence of sufficient cortisol, and also the effect of corticotropin-releasing hormone to stimulate secretion of ADH. High blood potassium, due to loss of production of the hormone aldosterone. Eosinophilia and lymphocytosis, which is increased number of eosinophils or lymphocytes, two types of white blood cells. Metabolic acidosis, also is due to loss of the hormone aldosterone because sodium reabsorption in the distal tubule is linked with acid, hydrogen ion secretion. Absent or insufficient levels of aldosterone stimulation of the renal distal tubule lead to sodium wasting in the urine and acid, hydrogen ion retention in the serum. How is treatment in Addison's disease? Treatment for Addison's disease involves replacing the missing cortisol, sometimes in the form of hydrocortisone tablets, or prednisone tablets in a dosing regimen that mimics the physiological concentrations of cortisol. Alternatively, 1/4 as much prednisolone may be used for equal glucocorticoid effect as hydrocortisone. Treatment is usually lifelong. In addition, many people require fludrocortisone as a replacement for the missing aldosterone. People with Addison's are often advised to carry information on them for the attention of emergency medical services personnel who might need to attend to their needs. A needle, syringe, and injectable form of cortisol are also recommended to be carried for emergencies. People with Addison's disease are advised to increase their medication during periods of illness or when undergoing surgery or dental treatment. Immediate medical attention is needed when severe infections, vomiting, or diarrhea occur, as these conditions can precipitate an Addisonian crisis. A person who is vomiting may require injections of hydrocortisone instead. Those with low aldosterone levels may also benefit from a high sodium diet. It may also be beneficial for the people with Addison's disease to increase their dietary intake of calcium and vitamin D. High dosages of corticosteroids are linked to osteoporosis, so these may be necessary for bone health. Sources of calcium include dairy products, leafy greens, and fortified flours, among many others. Vitamin D can be obtained through the sun, oily fish, red meat, and egg yolks, among many others. Though there are many sources to obtain vitamin D through your diet, many people choose to use a supplement. Crisis in Addison's disease. Standard therapy involves intravenous injections of glucocorticoids and large volumes of intravenous saline solution with dextrose. This treatment usually brings rapid improvement. If intravenous access is not immediately available, intramuscular injection of glucocorticoids can be used. When the person can take fluids and medications by mouth, the amount of glucocorticoids is decreased until a maintenance dose is reached. If aldosterone is deficient, maintenance therapy also includes oral doses of fludrocortisone acetate.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.